All right. So when we talked last week, earlier in the week, or actually it was last week, you were saying, I don't think I have much to talk about, but boy, things sure really changed, didn't they?
Well, gosh, I've been on the phone for the last few hours with something called the NRCC, which is the National Response Coordination Group, and they're actually FEMA and CDC and Health and Human Services. And the reason I was on the phone with them is because we have to move from a situation where we simply start basically distribute vaccines based on population and start to be able to predict where these big problem areas are going to be and how to get in front of them. Because as you know, that exponential curve, once it starts, it's extremely hard to stop. And if you wait a couple of weeks because you want to be fair to all the states and you let a couple of states get out of control, those states can really then overwhelm all the places you've done good at the rest of the place. And we're right now having, and sadly, well, happily, I'm from Michigan, so I love it here, grew up here, and so on. But people think I'm biased because I'm trying to say the Great Lakes now need to have that support because we're just out of control, and it's going to get worse. But sadly, what it's tracked back to be, and the reason I think we're the worst among the Great Lakes states is because we've got a ski community, and it turns out that if you look at the European outbreaks or Canadian outbreaks, it started with skiing.
Really?
Moved to the spring break and then moved to the snowbirds returning. And now it's going to continue on for Easter, obviously. And those cycles, that start of that cycle happened with the skiing, believe it or not. Yeah.
That question has come up from a lot of people on Facebook. Why Michigan? Why are we exploding? The other thing that I'm hearing, and I don't want to dump on the governor because she's been trying to damp this down, but the fact that we've had sports in high school and all that intermixing, that's also being pointed to as one of the potential causes. Is that what you understand?
Yeah, so I have a couple of charts about that. We'll talk a little bit about that if it makes sense. I'm sorry, I'm a little bit tired out because I was on the phone for such a long time with high-level guys who are quizzing me for the last 3 hours, literally. So,
I'm not a high-level guy, so I promise I'll go.
No, but our audience is discerning, so I have to get ready. So yeah, there are 4 reasons we think Michigan's having challenges, and we talked about that 2 weeks ago. The first big reason is actually we weren't as affected as many other states because of the efforts of Governor Whitmore. Frankly, she actually protected us, and we're on a peninsula, so we didn't get as infected as the other states, and so we didn't have as much natural immunity as a lot of the other states. That's the first thing that happened. We have a lot more naive patients to infect, for the virus to infect. The second big thing is the virus, right? The variants of the virus are coming in, and that's because we're a big hub, and we were the first to be infected because we're a big hub for the car industry. Things come over. They come from Central America. They come from Mexico. They come from Europe, and those groups have very potent variants out there that sadly it's not they're coming in the car parts. It's that we go and visit them. We have and because that's part of our business. We have to do that and engage with them, and then sadly people unknowingly bring it back and they infect people who are more vulnerable and have symptoms, and that's a challenge. And so those 2 things are special about Michigan. And then, of course, we've got, there were a couple other factors that we talked about last time as well. And they slipped my mind, but they'll come back for a second. There were 4 big factors, but those were the 2 biggest ones: the variants and the fact that we're a little bit more naive. We have those are the bigger things. We're on track on vaccinations. We're one of the better vaccinated states, but we'll see how that has shifted where the infections are coming in a second. But let me take a look at what we've got. I'm disabled from screen sharing, but I was going to show you some stuff.
Sorry. Yeah, I forget Dave was always doing that. Let me share a screen. Okay.
So yeah, I think he'll let you do it. I'm pretty sure he'll let you do it.
There we go. Well, let's see if we can do something here.
I may be sharing my screen here.
You are. I can see things.
Yes. Let me stop that. I forgot. That was one of the things I didn't look up. So multiple participants. There we go.
That could have been worse, Mike, depending on what you were looking at before the show.
Yes.
No, it looked very professional. Everything looked perfect. Yes. And we will take a look. What do you? Can you guys see what I've got without?
Yep. Yeah, beautiful. Yeah, just make it full screen.
I will on the current slide. Here we go. Yeah. Oops, this is the wrong date. So, uh, but the first thing I wanted to say was that we've looked at excess deaths, and one of the things that people are worried about is, that people are hesitant to take the vaccine, um, and completely normal to be hesitant. There's been a lot of, it's come on fast, right? We've done some very fast clinical trials, but we have found that there are very few cases under which you would want to not take a vaccine. In fact, I there are hardly any in the millions of people who are in line to take vaccines. I can tell you that there's almost no reason not to take this vaccine on the basis of what demonstrated efficacy and demonstrated safety in both the clinical environment where it's highly controlled. We've got people who are not taking the vaccine compared to people who are taking the vaccine, and we can see that's a 95% difference in terms of effectiveness. And as far as safety goes, we're talking about safety events that are in the parts per million, the low parts per million, 1, 2, 3 kind of events per million people who take the drug, the vaccine. And so there's no reason not to take the vaccine, because this COVID will kill you, period. It's real.
And the one thing that struck me, I saw this particular chart last week, Fred, and the one thing about it that really struck me was that everybody was talking about how suicides were through the roof because everyone was so depressed because of all the lockdowns. Suicides actually went down last year by about 3,000.
They're off the top 10 reason. Yeah, they're off the top 10 reasons for death. COVID's replaced it. And if you annualize what our current rate is, COVID could beat cancer. Now, it's not a competition that we want to see happen, but I think we'll have over 600,000 deaths in sort of about the same time period as we have 600,000 cancer deaths.
I also noticed the jump in heart disease deaths and diabetes deaths, and I'm wondering if that's because people are ignoring symptoms because they're afraid to go to the hospital.
There are a lot of people who will see cancer deaths go up because people have been stopping routine surgery around cancer, skin cancer, dermatology problems, things like that. We're seeing a cancellation on colonoscopies. We're seeing postponement of important diagnostics. And please, get your vaccine and go out and get those tests done, because we will otherwise see a spike in the other areas. Heart disease and unfortunately stroke and diabetes are also because we're being a little bit more sedentary than we were. We're staying home. We're not as active as we were going out shopping, going out doing things. You see the jump. I mean, the jump is shocking in diabetes, right? I mean, that's just a huge jump. And the jump in heart is also way off the charts, right? And so be out there, get out there, get in the fresh air, do more stuff. Try to take care of yourself and see your doctor, because otherwise these other factors are going to creep into the equation. But I just wanted to point out that this is 2020, the year 2020, 345,000. We are already at closing in as far as excess deaths go at around 600,000. And the number of people we actually diagnosed is around 550, 560, but as far as excess death, it's over 600,000. Which is really what you want to look at. Some people aren't diagnosed before they die and are then not considered COVID-19 deaths. But that's in this year we will probably exceed cancer. And of course, these are the numbers. So for people who don't think COVID is going to kill you, I had a good friend in high school, sadly, and he said he was just at his sister-in-law's funeral. He's about our age. And he said, a mask and vaccination would have helped, but she just wasn't a believer. And unfortunately, it killed her. And it was just sad, just a tragedy for the family. And I hope we can avoid that by some of these discussions we're having and try to get over that. So just wanted to say, it's out here. But Michigan is really, we are the worst state in the country right now. By a lot, and I'll show you some of the data. Right here's a 7-day moving average. We're at we're closing in on 8,000 cases a day. Those Johns Hopkins numbers, And you can see we're just as high as we were back in November around Thanksgiving when we thought that it couldn't get much worse. We're just as high as that right now. We're the only state in the union to look this bad. Because if you look at the other states, here are the other 4 worst states. If you want, and you can see Michigan is the blue line, right? And you can see that everyone else is starting to trend down, and Michigan's still going straight up. And that's not where you want to be. And the reasons I said is you can start to see this is the 350 days right around February 15th. Everyone went skiing, everyone had a great time, came back, went down south, had events down south for spring break, came back up for Easter, and all that spread just is a disaster. And you can see the other Great Lakes states, New York, Pennsylvania, Florida, New Jersey, are the worst as far as 7-day case rates go. If you look at the Midwest, Michigan has 16 of the highest per capita cities in the country out of the top 20. 16 out of the top 20, and we don't have that many big cities. I don't need to tell you. We just don't have that. And so it's not a matter of the fact that we're all getting compacted into a small area like New York or Manhattan or Chicago or San Francisco on a peninsula. We are there because our community spread is so high, our prevalence is so high, and whenever you have that high prevalence rate, you get more reinfection, more capability for mutations, and more capability for spread. And that's what's happening in Michigan. And here is against the United States. United States, I don't know if you can see it, is this blue line, and it's basically flat, right? Since February, mid-February, nice and flat, all smooth. And at the same time, that flattened out. This is new cases per 100,000. 4 times worse than the rest of the United States. When you see people having a great time in South Dakota or in a state that's in control, and that South Dakota is not an example of one, sadly, but if you see one that's in control, like Washington State is in better control, for example, right now. And you're seeing them having fun, having a great time. That is not our situation. We've got to be adjusting to what is reality on the ground. And reality on the ground is Michigan is 4 times worse than the average state in the United States. Most of the other states give you a sense of this, are down in the 5 to 10 range, and we're at 80. We're kind of 8 times worse.
Even within Michigan, I was looking at West Michigan, where I'm originally from, and it's really bad over there. So,
yeah, and before we were worried about remember before we were on a peninsula and we saw the encroachment coming in from Wisconsin, coming in from Illinois, Indiana. That's not the case anymore. Those counties are now the best in the state. Our worst parts of the state are in the thumb and north. Not in the UP, but in the northern Lower Peninsula is the worst part of our state, and the west.
Yeah, the thumb was like glowing bright magenta the last time I looked at the map. That's really rough there. I'm just curious about one thing about the whole skiing thing. Did Colorado have a similar experience? Because that's like the #1 skiing state.
Yeah,
right?
Colorado's having some challenges as well. Okay. But what we're really seeing, this is in Canada, where they open up the ski slopes, Italy and Austria. And the problem in our state was that we had the B117 variant. Colorado didn't have so much of the B117 variant. And so we spread it among ourselves. And that's what really caused it, is because we just don't understand that this is when you have a variant that's 50% more transmissible, that you just can't use the same old masking techniques anymore. You can't use the same old distancing techniques anymore. What we used to work doesn't work. And we didn't adjust, and neither did Italy, neither did Austria, neither did Canada. And we had the bad variant, and Colorado dodged the bullet. They didn't have it. It's working their way toward Colorado, but I think they're going to miss it. I think we're going to start to see Michigan, though, from our modeling, my modeling. I think Michigan is at the tip of what the peak will likely be. It may go up slightly beyond this, maybe 10-15%. But after that, I think we will see it coming down. Sadly, as you know, what happens after the case rates increase is then the death rates increase about 5 weeks later.
Yeah, death is a lagging indicator here, right?
Yeah. And so that's what we were talking about with FEMA today. We were saying we can probably impact the tail end of this curve by increasing the vaccinations and surging the vaccinations to Michigan. Unfortunately, they're not willing to do that at this point. And that's disappointing because we made
well, there's huge numbers of people now moving through Ford Field, right? Because my 31-year-old son got his first shot Friday at Ford Field.
Yes,
and he said it was literally a military operation. You know, they're taking thousands of people through there a day. So
yeah, if you want, I can show you what some of that looks like. I've got a slide on how to do mass vaccination. You can get up to if it's properly automated, you can get 20,000 vaccination shots in a day. Using it's about 4.5. That's about every a vaccination every 4.5 seconds in those sites. To give you a sense of just how much production. I'll show you how that looks in a second. It's in a different slideshow, but I'll show you how that looks and what the differences are between going to your local pharmacy and then going to a mass vaccination site. It's a completely different operation, and it's really interesting to see from a manufacturing perspective. Of course, we are great at manufacturing, right? And we know how to manage inventory, we know how to manage throughput, we know how to manage those things. So Michigan is a leader in doing some of that work. Here, unfortunately, here are the hospitalizations, and it's just following straight behind, right? 3,700 hospitalizations. At our peak, we were at 4,300, and we'll probably exceed that peak slightly at 4,300.
Yeah, and I remember hearing at the beginning of this thing, there are only about 10,000 hospital beds in Michigan.
Yeah.
So right now, you've got a third of the hospital beds taken up by COVID patients.
40% of the available hospital beds. You need to have some reserve. You can't just dump the hospital bed and change it. You've got a little bit of. If you're working at 85%, you're really, really full. Trust me.
yeah, and people are still having babies and having heart attacks and stuff.
Yeah.
I mean, that's the real problem.
Yeah, exactly right, man. Exactly, and so you can see from February, where we had that baseline trough, we thought everything was going great, to today. Wow, the rest of the United States made it happen, and we just turned right back up again, which is disappointing. Here are our daily testing. I've drawn in a red line to this because we should be at 3%. I tried to draw it right around 3%. It looks like I may have been a little bit too generous on the line.
Oh, yeah, down at the bottom, I see it there.
Yeah.
It's way below where we're at, that's for sure.
Sadly, but this is our this is where we should be in terms of testing positivity rates, right? And so the problem is when you're at 18%, you should be at 3%. That means you're missing probably 6 times more than you really have in terms of real COVID cases. In terms of and so we're missing the testing. And the testing, of course, is your first indicator, right? You want to understand where the COVID is, who has it, as soon as you can, and we can find that out after 4 days. If you wait for people to go to the hospital, that means you've waited kind of 2 weeks. If you wait for people to die, it means you've waited 5 weeks. By that time, the whole state's on fire. And so our leading indicators just aren't being satisfied here, and that's part of the problem. We need to have antigen testing to understand where the COVID is. We have serology testing to know where we're protected and who's protected by already having the disease or who's having a vaccine. And we need to follow that up with genetic testing to know which variant we're actually going after. That infrastructure, we've got 3 laboratories in the whole state that can actually do something like this, and we're utilizing them pretty effectively right now, but it's just not enough in terms of genetic testing and understanding sequencing. So you talked about the vaccine coverage, and we think we're seeing an effect. Now, what we did is we looked at see the red those are what we did is we looked at the last 365 days, and then we looked up until March 1st, and then we looked at the population of infected people after March 15th. So by March 15th, we had quite a few people vaccinated, and those were in the far right-hand side. You can see that we are right now in April, we're up at about 70% vaccination rates for initiation and about 60% vaccination rates for completion. And if you compare the people who were infected back in November, that percentage of population, and then in that time period, all last year, versus who are currently infected, that caseload is down by 3-fold, right? So we would have anticipated that if we had 1,000 people, 600 of those would be probably over 65, 70. Instead, we're only seeing that's being about 200. for example. I'm not saying those are the exact numbers, but in other words.
So let me boil that down for you. Us geezers have gotten our shots, basically. That's starting to show up, right? So that's okay.
And if you're between 50 and 60, now unfortunately we did the charts that the chart following here are 50 to 64, 65 to 74, and so on. Unfortunately, they did it in 10-year increments. So I've got from 60 to 70 and from above 70. So from above 60, those cases are down from last year 30%. Now you can see though that they're only about 24% fully vaccinated. So that's, we're starting to see a little bit, so it's down 30%, we're starting to see a little bit of a shift. What's really interesting though is what's happening to people under 19. The proportion of cases that are in the people under 19 are up twofold. So those people haven't been vaccinated because only Pfizer gets 16s and the 19s. These guys are looking at under 19s year olds. If you look at 16 to 19-year-olds, they're up 15%. So some of them could be vaccinated, most of them aren't. Where we're really seeing the upsurge is in the people between 20 and 29. They're only 10% vaccinated. Their caseload, they're up 50% in terms of proportionality.
Yeah, those might be the people that went skiing and then went to Florida. So.
Yeah, maybe so. And the people between 30 and 39, their cases also, you can see they're only 14% fully vaccinated today. That case proportion up 30%. So it gives you a sense of how the vaccine really starts to take these parts of the population completely out of the equation as far as getting infected goes, and then leaving exposed those who haven't been vaccinated. And you can see that the powerful shift that we're seeing from most of the people being over 70 and 80 to most of the people being now under 30. And what's happening is that's not the death rates. That's just what's going on as far as case rates go. But the death rates, sadly, may follow. Luckily, not as heavily because they're not as these cases of the younger people aren't as virulent, aren't as deadly. But we will see that sadly follow right along to some extent. Most of the deaths will still occur though in the above 70s for the next a month or so, because they're still not fully vaccinated. So if you're in that group of above 70, just because the cases are down doesn't mean the death rates are down. It's significant.
Well, I just got my second Pfizer dose on Friday.
How do you feel?
Well, my arm was kind of dead for a day, but other than that, I felt great, so.
Good. Yeah, a little bit of, it is a little bit of a, it's lipid, so it's a little bit more, it's not, it's a little bit more thick to inject in, but it's a small amount. For Pfizer, it's 30 microliters, so very, very small amounts of that.
Yeah, I got the Moderna shot, and I officially became 2 weeks past my second shot on Friday, and I had like zero side effects.
Beautiful. I also had no side effects. First one was a little. I felt a little bit fatigued. The second one, no side effects at all for me.
Well, you can't afford to be fatigued, Fred. So we were going to send you a case of 5-hour energy, right? So
yeah.
I started off at 5 a.m. this morning with coffee, and that's got to have to. And the progression of coffee, bolus effect going up during the course of the week.
I was going to say, I think we ought to send him a case of something else once national cases drop below 500 a day or something.
Yeah, there you go.
I'll be ready for
more
that,
cognac, guy. Fred.
Yeah, I love it. Yeah, we'll have. Oh my gosh! So you can see that. Hear all the new lineages that we're tracking, that we're seeing so far. Now remember, we're only tracking about 0.25% of total positive cases, right? So we're way down as far as here are the positive case. Let's check what variant has infected this person. So we're way down on that tracking, but it gives you a general sense of just how many variants you're watching, how many worries to worry about. The 1427s are very close to the 1426s that we see in 62s that we see in California. The 1361 is very close to the 1351 out of Brazil. That's one to really watch because it's about the vaccines are about 6 times less effective with that versus the V1 variant. The 1575 and 93s are close to the dark variants, and then you see the D117 variants on the purple. So those are some of the ones we're watching for. I wanted to talk just quickly. I know we only have, a couple of seconds left. Gosh, this goes fast, you guys. There have been some issues about AstraZeneca, and as you know, Johnson & Johnson had some issues with Emergent. Their contract manufacturer. They left, unfortunately, some these mRNA vaccines have very sticky components. Some of the old mRNA, some of the old adenoviruses that are used as a vector uh, with AstraZeneca were left behind in the J&J batches. They killed all those batches. They said, nope, we're not going to send them out. They're spoiled. 15 million batches, which is why our number of J&J vaccines went down by about 20, close to 20, 4,700,000 in a week. And that was surprising because most of our batches actually all of our batches come in from the Netherlands, but it's all connected, as you know, in the manufacturing operation. So here's what the AstraZeneca are looking at. Basically, what they look at is risk versus reward. And what's interesting here is that overall, we don't get very much harm from the vaccine. You can see that one little dot. It's a 1.1 per risk in an incidence of 10,000 people. This is AstraZeneca. So this is not available to us. But what's happening now in AstraZeneca is they're starting to look at Johnson & Johnson. And because they both use an adenovirus vector, they said, maybe we want to look at this and see if there's blood clotting issues with Johnson & Johnson. So far, nothing's been found, but they're watching and they're trying to understand better. And so I wanted to give you a sense of, so right now there's nothing to worry about, but I wanted to give you a sense of what they are looking for. So, you know, we can understand when they come out with results. And so if you're in a high exposure risk group, and this means that you're in a population with an incidence of 20 per 10,000, and we are in Michigan, to give you a sense of this, we are vastly above that, right? So almost everyone's in a high exposure group in Michigan. You can see that basically, if you're 60 to 69, the risk is 0.2, and the chance that you're going to get the reduction in the risk of COVID is 127. So that's a huge benefit ratio, right? 127 to 0.2. It's literally, you know, one in 1,000 over 1 in 500 kind of risk reward. Once you go down to 59, the benefit, there's a slight higher risk of slightly higher risk of these coagulants occurring versus about 1 in 100 of preventative of prevention. So again, huge benefit, right? 0.4 to 100. When you get down to 40 to 49, it's 0.5 to 50. Now it's starting to get, you know, kind of 100 to 1. When you get down to when you get down to 30 to 39, 0.9, and now it's 30 to 1, right? And when you get down to 20 to 29-year-olds, it's about, you know, it's about 7 times more effective to take the vaccine than not. At that point, they said, you know, 7 to 1, you know, we don't. That's a risk that we want to start to say. Let's let people take, and the people under 30, let's let people take them, give them other vaccines. They're better alternatives. But above 30, the benefits are still overwhelmingly in favor, and so we would continue to go with the AstraZeneca vaccine. That gives you a sense of the way you look at risk and benefit, right? Here's how much risk there is on a side effect of blood clot, versus here's how much benefit you're going to get of avoiding and preventing COVID. And that's what we want to look at. And when you're older, in our age group, the benefits are vastly outweighing. But when you get to the very young, it may be that you want to move over to a different vaccine. So that, and they did that. That's a high exposure risk. Here's what for medium exposure risk is, and that's not our case in Michigan, for example, at all right now. And here's what it looks like for low exposure risk. When you get to the low exposure risk, you can see, and here's why they took the cutoff. that's about 1-to-1, right? 1.1 positive versus 0.8 negative. But in the state of Michigan, it's always going to be extremely positive to take any vaccine you can get, because AstraZeneca is the one that is the most tricky, and it's not even been approved yet in the United States. Johnson & Johnson is the one that's most likely, but again, it is most like AstraZeneca, but it is significantly different because it uses a completely different vector. Johnson & Johnson uses an adenovirus that's based on human cold, and we always knew that AstraZeneca's would be a little bit trickier because it uses one based on a chimpanzee vector, which we would have some reaction to. And we think that's the problem. It's a chimpanzee vector. And again, these are chances we saw 15 cases out of hundreds and hundreds of thousands of people who have taken this vaccine. We saw 15 cases that were associated, possibly not correlated with, but possibly associated with the AstraZeneca vaccine. So that I just wanted to give you a sense of what's going on there. Basically, it was poorly managed. They didn't do a very good job with clinical trials. That's why the United States said, no, go redo your clinical trials, show us what the data is again, demonstrate this in a clinical setting. AstraZeneca is getting close to the point where they can show 30,000 patients being safely administered this vaccine. My guess is it'll be kind of toward the end of May where we have AstraZeneca available. We've got 20 million doses of this stuff already, and we keep getting more and more and more of it stockpiled because we've agreed to buy up to 300,000 doses of it. 300 million doses of it. We have 20 million doses now, 300 million are coming. And we have a choice. Do we want to use it for the United States, where we already have 3 very effective vaccines that are slightly, frankly, I think until I see the clinical data, maybe slightly better? Or do we want to give it to Mexico and other states where we keep getting reinfected and having lots of variants around us as we get to a point where we don't have to worry about supply anymore? Because we're getting, in about 3 or 4 weeks, we will have more supply than we will have demand.
So I'm thinking the Canadians need it, right?
Canadians would be desperate for it, and it'd be great to send it over to them.
Okay. Final point before we sign off here. Yeah. Last month, you were saying you thought by the 4th of July we would kind of be under control. In light of all this, have you revised your prediction? Or
Yeah. The governor I don't know if you heard, but the governor just said to everybody, based on our failure partly based on our failure of getting a surge of vaccines over to our state, that she thinks that we're going to have to, that people who can work from home should continue to work from home for the next 6 months.
Oof.
Yeah.
So fall then, huh?
I'm still hopeful that we're going to have the worst of the scare by the end of May, and that we'll have enough people vaccinated by the 4th of July that we'll have at least a slightly, a chance of having, the family getting together and an outdoor barbecue in a safe way. But I think it's going to be delayed, sadly, because we just have to come down again from a higher peak than we were at before. And we're going to have to get more people vaccinated in order to get to safety, sadly, than we did back in February.
Okay.
I wish I had better news, but this thing just doesn't stop, right? It's just relentless. If you give it just an inch, it'll just come in and take over, because that's the way nature is. You know what it is, like you don't leave your garden. It just gets you.
Traditional four-year students love Lawrence Technological University's thriving campus life, but LTU has always met non-traditional students' needs too. Lawrence Tech offers over 100 degree and certificate programs that can get adult students started or back on track. And most of our classes are conveniently offered evenings at our beautiful Southfield campus or online, so you can balance your social, family, and work life even while you power up your career. Lawrence Tech, where Blue Devils dare.